This is the IPTS System of Belonging presentation from Team 6b. My name is Benny. In our presentation, we are first going to talk about the background of Hope Foundation and physician burnout in the COVID-19 era. We will then give our definition of radical belonging and give our recommendations and of how we can implement the radical belonging in our healthcare system. We are finally going to talk about the impact of implementing our recommendations and how we can measure these long-term success. First, a background about Hope Foundation and mHealth Fairview. Hope Foundation is founded to provide transformative change effort of mHealth Fairview to bring about more equitable outcomes and inclusive environments to improve the experiences for patients, employee, and the community. And mHealth Fairview is a partnership between Fairview Health Services, the University of Minnesota, and the University of Minnesota physicians. As Hope Foundation has noted, there has been significant burnout in healthcare workers in COVID-19 era. Burnout has already been an issue prior to COVID-19 pandemic, with an estimated of 30 to 40% of healthcare workers experiencing burnout, costing the healthcare system approximately $4.6 billion a year. Those who experience burnout are more likely to report making recent medical errors, plan to retire early, and are associated with reduced patient satisfaction with medical care, and also patient adherence to treatment plans. Doctors, nurses, and other healthcare professionals have traditionally viewed their work as a calling. They tend to enter their field with a high level of altruism coupled with a strong interest in human biology focused on caring for the ill. These traits and goals lead to considerable intrinsic motivation. However, sometimes our healthcare system provides external stressors and motivators onto the healthcare workers by increasing the patient load, increasing hours, without realizing that these external stressors erode and destroy the intrinsic motivations of healthcare workers, leading to amotivation, in other words, burnout. And COVID-19 has exacerbated the stressor in the healthcare system, in which the burnout is already epidemic. COVID-19 caused healthcare workers to face longer hours, having to step in for sick teammates, and facing, especially initially in the pandemic, facing a lot of life and death situations. According to one study performed in Vancouver, Canada, the prevalence of burnout was 68% amongst the healthcare workers surveyed, and another 22% feeling low personal accomplishment. In addition, 21 reported that they were considered quitting the profession or had quit a position. Women are more likely to report emotional exhaustion and feeling low personal accomplishment than men. Ethnic minority physicians are more likely to report feeling lower personal accomplishment than white physicians. There was no difference in emotional exhaustion or depersonalizations by ethnicity or sexual orientation in this particular study. So how do we help the healthcare workers to cope with this increasing level of burnouts? This is how we're going to introduce the radical belonging.
The concept of radical belongingness is gaining popularity, but what does it mean? Through a literature review and publicly available information, our team developed our own definition of radical belongingness. Our team believes that radical belongingness is a transformational framework that actively and intentionally provides an environment of inclusivity and empowerment for people of color. Additionally, radical belongingness includes both the words radical and belongingness. So we looked into the Merriam-Webster definition of each of these terms. Radical is defined as of or relating to or proceeding from a root or origin. Belongingness is defined as a close or intimate relationship. Other synonyms for belongingness include closeness, familiarity, and nearness. Furthermore, radical belongingness should include social, academic, or in our case, occupational, and demographic belonging and the relationships between them all. Lastly, it should include revolutionary change in the fundamental nature or root of current workplace culture to emphasize the belongingness of people of color. So why is radical belongingness important for healthcare teams? We decided to focus on 3 reasons why it is important, but there are many other additional reasons as well. First, radical belongingness improves interprofessional teamwork. A study conducted by Rosen et al. Concluded that coordination and delivery of safe, high-quality care demands reliable teamwork and collaboration within as well as across organizational, disciplinary, technical, and cultural boundaries, and that the quality of teamwork is associated with the quality and safety of care delivery systems. Second, radical belongingness improves employee retention rates and satisfaction. Again, Rosen and his team concluded that improving teamwork among healthcare professionals is increasingly viewed as a viable strategy for managing the numerous workforce challenges, including recruiting and retaining skilled staff during nursing. Lastly, radical belongingness improves patient outcomes. Rosen's team stated that connections between the quality of teamwork and patient outcomes and healthcare worker outcomes. Another study conducted by Thomas found that how team members form cohesive social units, interdisciplinary function, and adapt over time to achieve shared goals and manage complex work contributes to educational, technological, and work redesign interventions to improve care delivery, patient outcomes, and ultimately public health.
Our 3 proposed interventions are an employee assistance program, mandated staffing ratios, and a wellness policy and program. The first intervention in this proposal is the Employee Assistance Program, or EAP, which is modeled after the Federal Occupational Health, or FOS, EAP, which is part of the DHHS Program Support Center. The services planned to provide are assessment, counseling, referrals, financial and legal services, crisis response, management consultation and counseling, educational presentations, orientations, and outreach, as well as a childcare program at our main locations. The main addition to the FOS EAP is addressing childcare, which is a major concern for many employees, especially those who come from disadvantaged backgrounds. The Workplace Outcomes Suite, or WOS, is a verified measurement tool used by many EAPs worldwide, including the MINSER study on the FOS EAP on which our EAP is based. This will allow a direct comparison and indicate program efficacy as compared to the FOS EAP. Our expected results are an improvement in life satisfaction and workplace engagement, a reduction in workplace distress and absenteeism, and an overall return on investment similar to other EAPs, approximately 3 to 1. Perhaps the most important aspect of our EAP will be our emphasis on radical belonging. The EAP will be built with an emphasis on cultural competency and personalization of services, including managerial and staff training in cultural competency and clearly defined goals to guide individualization of services. There will also be a professional translating service available to improve communication within and about the EAP, and EAP managers must be involved in advising future goals for the HOPE Commission. The program will collect usage and outcomes data, including race, ethnicity, income, gender identity, and sexual orientation, which will allow the program to identify utilization gaps. An EAP advisory committee will be created at each workplace to identify trends, gaps, and response to the program, and to streamline communication between program sites. Feedback will always be encouraged. and the program will provide an established process for employees to address concerns in an inclusive and safe environment. Furthermore, the program will seek to normalize utilization of the EAP by employees by developing inclusive, multilingual promotional materials to encourage EAP usage. It will also encourage and educate managers and other leaders to use the program, which will inspire other employees to use the program as well.
Another intervention we would like to address is staffing ratios. Many studies have found a multitude of negative effects when there are high staff-to-patient ratios for prolonged periods of time. There are tolls on healthcare workers' mental and emotional health, leading to burnout and increased workplace tension. Add in the increased stressors brought on by the COVID-19 pandemic, and more people are leaving the profession than ever. Studies have shown that minorities face an even larger amount of stressors. Our 5 team members in the case study are all looking to leave because they are feeling the effects of burnout. In California, there are mandated nurse-to-patient ratios. Other states have slowly been adopting similar policies. Some states even mandate that each institution have a staffing committee. One study examined the transition from normal staffing patterns to adopting acuity-based ratios. The study found that there were some obstacles to a smooth transition, namely resistance to change and increased stress from the initial change. However, the study did find that once the new system was in place, the benefits were huge. Stress went down, staff members were happier, and patient care quality increased. The study found that the transition was easiest when there was interprofessional support. Hospital management needed to step in to help educate on the new system. Unit leaders needed to encourage the change, and staff needed to support each other. When there was support, units adapted much quicker to the acuity-based ratios. This leads to our interventions. There should be mandated lower staff-to-patient ratios, and they should be based on acuity. Research shows that lower ratios have better outcomes for staff and patients. We also suggest adding councils to help address staffing, as the councils are more closely tied to the units and can determine individualized transitions to acuity-based ratios. The benefits of these interventions are greater interprofessional teamwork, improved care, reduced turnover, better work environment, and improved health of staff. When staff have the time to provide quality care, they will feel less stress and will be better able to interact with the team to meet the needs of the patient, instead of worrying about running out of time. The metrics of success for this intervention are decreases in reported stress levels by staff and decreases in staff turnover.
Our final intervention is a wellness policy, which would look at the employee as a whole and kind of address both their mental, physical, social needs. And so our first part of that program would include a meal assistance for those who are financially needy, low income, high financial burden. This would allow for them to have maybe meal stipends or meals at a reduced cost. And another part of the policy is a lunch and learn, where I actually saw this implemented from Grubhub, oddly enough, at their corporate office, but you could do like an every other week or every other month option where the organization would provide lunch to their employees, and they would be able to cover a topic that was of interest to them, such as a new medication maybe that just hit the market, or working on coping strategies, so you could kind of do something different each month with it. Another thing that we could do is provide a gym and workout space on campus with classes for employees. This would allow them to have, like just a one-stop shop for all of their needs between work and working out, and would hopefully help for a better work balance, and then also, take away that cost of an extra gym membership, and it is just everything in one spot for them. And I also was looking at how we can retain providers and staff in middle and low income areas. And the big things that I saw in different articles talked about providing improved training and living conditions in those rural or low income areas. And so we're doing that with housing assistance or also student loan payback, especially right now. I know that second one is big. Another option would be a mentor program, and so this would be a partnership between an experienced employee with a newer employee, and it could be both a balance of talking about life, but also obviously talking about work, what one party could do better. And it would start as a mentorship, but eventually hopefully turn into a partnership would be the ideal of that part of the policy. And then finally, we have what I've seen in other corporations do is having somehow season tickets to offer to different sporting events or maybe concert series where you get a box at a concert venues and you rotate who it goes to each month or each event, and it's a way for employees to either bond outside of work, either with their coworkers or also just with their family members, and just kind of a nice perk from the organization.
Hello, my name's Jefferson Tyler, and I'm going to talk about how we can measure some of the success and interventions that we will have. First, we can measure the retention rate. Significant number of studies have shown that employee satisfaction is directly related to retention, and that additionally, increased retention decreases training costs, decreases error rates, and leads to higher productivity. So that is a good overall measure. Another measure is sick day requests. The higher rates of burnout are shown to show higher rates of sick days. And then two of the measures that I have are questionnaire-based. There's this job satisfaction questionnaire designed by Ahmad et al. That is a validated survey specifically designed for measuring satisfaction in healthcare professionals that measures in 8 different domains using 34 different questions. And the fourth measure is employee mental health questionnaires, specifically PHQ-9 and GAD-7, regularly given to employees. Decreased overall scores have shown to be correlated with decreased burnout. And for these questionnaires, they would scores would be averaged across departments and the hospital as a whole rather than tracking individual employees' scores. As part of our long-term success, we have to make sure that it is measured correctly. Having anonymous surveys completed monthly and stratified random sampling of employees could help ensure adequate measurement. Measures of success should be gathered at least quarterly and discussed with the hospital board of directors, adjusting plans as necessary. I think it's really important, especially that we adjust plans as necessary as the project is being implemented, leading to better long-term success. And then additionally, a wellness officer who chairs a monthly meeting of wellness committee and attends board meetings to promote wellness and to help ensure that plans are being discussed at the highest levels of leadership. And then another area that could be of a concern to leadership is the financial aspect. A lot of our proposed interventions are costly. However, I think it would be important to remind the hospital leadership that initially costly ROI on wellness programs financially is almost always within 4 years, and there are also non-financial reasons that we would do a wellness program like this. And then as part of this program, expanding our success to other hospitals within the same system and around, kind of having this city on a hill where the hospital is the example that could be seen by other hospitals, greater success rate, lower error rates, higher retention, better employee satisfaction, hopefully could help provide examples to other hospitals. And one way we could facilitate this is liaisons who could be members of the wellness committee or other hospital employees who could assist in piloting programs at other hospitals and discussions with other hospitals.
During this case presentation and IPTS seminar, I learned the importance to learn the viewpoints from different healthcare professionals of different disciplines. In order for the healthcare team to work efficiently, not only should we listen to each other's recommendations, we should also strive to understand each other's perspectives and where we are coming from to help the teams work more efficiently.
I learned the importance of openness and receptiveness when communicating in a team setting in order to learn from our unique experiences and perspectives.
Through this experience, I've learned that creating an inclusive workplace requires persistent, ongoing organizational efforts to train staff, but especially managers and their other workplace leaders in cultural competency.
This project really showed me that caring for an entire person cannot be done just by one individual. A whole team is required. And within that team, there needs to be open communication in order for the highest level of care to be provided.
I learned that in order to care for any patient, providers must in turn be cared for. It's impossible to pour out of an empty cup. Open dialogue among all parties, clarity of expectation, and unwavering support of executives and management are key foundational aspects for success.
What I learned is that when doing a project like this, it is very important to listen to all health professions and frontline employees to ensure that plans are implementable and actionable and help employees.